Thank you all. It is indeed an honor to be here today, and it was an honor to accept the invitation to join you in celebration of not just Social Workers Month, but also to present on this very important topic. In preparing for this, I spent a great deal of time with the social work staff in electronic and telephonic communication, and I really want to acknowledge the great deal of time and energy that was put into this as a collective effort to assure that the content represented not only the best in terms of state of the art of knowledge in the area, but also reflected elements of interest for the audience, you, the consumers of this discussion today. And I hope that at the end of it, you find that the time that you've taken from your very busy schedules will prove useful, not just in terms of your own knowledge, but for the elements of service that you will provide to the communities. All right. I also need to make the disclaimer that though I'll be referencing certain institutions or potential products, I have no vested interest in any of the products. There is the disclaimer. I don't own any shares in anything, thank goodness, sometimes. And I'm trying to provide to you a very broad cut of the information that is available to us all. I think that's pretty much for the disclaimers and the introductions, and with no further ado, I'd like to go ahead and get started in the presentation. So it's important for me to begin with an element around our learning objectives to orient and set the compass for where I'd like for us to go today. There are at least four broad learning objectives. One is to understand something more about the importance of addressing LGBTQ issues in the healthcare setting. And we'll come back to talk about this alphabet soup in a little bit. To assess some of the common barriers in achieving and optimizing healthcare, and these words are very important, achievement and optimizing healthcare for LGBTQ individuals and their families, to describe and briefly demonstrate examples of resources available to you that will assist you in doing this work, and to explore and identify individual and organizational skills that promote and potentially hinder inclusive and patient-centered care for LGBTQ individuals. Before I go on to look at this in terms of examining the context, I really want to highlight some of the elements that, for me, support why this is so important. Over the history of healthcare, we know that many things, we call them social determinants, non-medically prescribed elements of the health environment, have impacted the quality and type of services that people receive, including inadequate assessments, poor diagnostics, poor patient interactions, disruptions to patient and family systems, and many others. These hold true for LGBTQ individuals, and it really undergirds why this is an important topic. In preparing for today's presentation, of course, I went to your webpage. I mean, who doesn't know about the Hospital for Special Surgery? But I had to go a little bit deeper and look at some of the areas in which you have received accolades. And you're at the cutting edge of so many areas, and you've honed a very, very particular knowledge skill for patient service delivery. So I believe that if you are at the forefront of those areas, you can also be at the forefront of integrating LGBTQ content into thinking about how you engage patients and how you transform healthcare systems to make them very accommodating for individuals who are LGBTQ. So why specifically is this a relevant topic? Well, this is relevant because the best estimates we have are that anywhere from 5 to 10% of your patient populations will be LGBTQ, whether they acknowledge it or not. And I think this is an important point to make. It's whether they acknowledge it or not. So whoever's sitting in front of you, 5 to 10% of your patient pool at any one time. And that's by self-identified patients. The numbers could be actually higher for individuals who don't identify as LGBTQ, but engage in behaviors that put them in the category of LGBTQ. The issue is one of a matter of health equity. This is an important point to make. Addressing issues arising from disparate care for LGBTQ patients, as I noted earlier, contribute to improving healthcare outcomes and eliminating health inequalities and inequities. This is a matter of ethical, professional, and organizational responsibility. There are, as you well know, increasing legal and regulatory requirements and policy agendas that are being set that enforce with penalties for you not complying with these issues. And so if nothing else, that's out there and looming for all of us. And your patients need and deserve well-informed providers who can address the whole person. A sensitive topic is where we're going to go today, and it provides a unique opportunity for your professional and personal growth. And again, I think it's consistent with the state-of-the-art and cutting-edge mission of your hospital. When we think about health disparities as a label, it's important to recognize that there is a historical definition that we've used, and it's one that focuses on racial and ethnic differences in healthcare that are not attributable to other known factors. But when we look at the literature in this area, there is an alternate definition, or what I call a newer definition, that views health disparities from a three-pronged approach, which consists of applying the most appropriate technologies and understandings to achieving the most desirable outcomes for the intended groups. And this moves us from a discussion solely around disparities to a discussion of inequalities and inequities. And when we talk about health disparities, it's important to understand that health disparities don't occur in a vacuum. They occur because critical decisions are made, either at the patient level or systemically. And if we're going to engage LGBTQ individuals, it's important for us to recognize the relationship between both the patient-provider issues and the systemic issues that produce the context in which patients and providers come together and health services are delivered. So despite the fact that the estimates say that there are between 5 to 10% of your patient populations at any given time who are LGBTQ, there are few rigorously designed studies that address differential healthcare outcomes for LGBT individuals. And in fact, just before I came over here, I sent to the social work team an additional resource, and they'll have it available for you. I ran a literature review, this is not in the presentation. I hope you don't mind me taking a couple minutes because you now have it available to you. And I went on Medline, I combined Medline, Cinol, PsychEd, ERIC, the typical culprits. I only ran it for a 10-year period because I wanted the most contemporary results. And I used the key terms health, lesbian, and gay. And I got a hit of about 938 to 1,200 articles. And I only wanted peer-reviewed articles. I didn't want dissertations and other elements. But then when I added the other terms, not mental health, not HIV, and hospital-based care, that 900 went to 23 articles. 23 articles over a 10-year period, which then underscores what I'm saying about the dearth of knowledge that we have in this arena. And were I to have eliminated the terms adolescent or youth, it would have gone fewer than 22 or 23. So what I've provided you with is the abstracted form of those 22 articles, and you have them here, and they're available to you electronically if you'd like to go through those. I didn't think it was important, and I didn't want to take up time going through each of the 23, but I did want to make that available for you. So if we think about what the literature is telling us, and when I review the literature and having worked in this area for about 20 years, there probably are not a lot of biomedical differences between LGBT patients and non-LGBT patients. However, the contributing and unaddressed social, contextual, psychological, developmental, interpersonal, and environmental factors are abundant, and they can produce deleterious outcomes for LGBT individuals. This is moving us into the realm of social determinants of health. And again, if we were to consider the underlying biomedical issues, and if I'm talking to nurses and doctors and PAs and others, you know far more than I do about the underlying biomedical conditions. So again, looking at the individual from the physiological or cellular level, or looking at x-rays, they may not look different, but the determinants of how people uptake health, how they engage health providers, the things that people become sensitive to in your own languaging, in your own systems, they start to look very different when individuals have had a historical or developmental or psychological experience that predisposes them to certain healthcare outcomes because of cultural systemic factors. And that's what we're really talking about today. This is a relevant topic also, as I said, because of increasing legal and regulatory requirements, including the Joint Commission's emphasis on patient and family engagement, patient assessment, treatment, including communication with patients at all phases of the patient-provider interface, appropriate care and treatment across the lifespan, and end-of-life care and directives. When we assess some of the common barriers to achieving and optimizing LGBT care, there are at least 3 distinct cuts in the literature: personal and individual, interactional at the patient-provider level, and organizational. And that's the way I'd like to take the rest of my time today presenting our information about this important topic. And because I'm an instructor, I believe in definitions, and I know this is a messy slide, so I don't expect you to read all of it, but there is a quiz before you leave the room today. GLBT, LGBT, whichever way you want to use it, it is an acronym that refers to gay, lesbian, bisexual, and transgendered individuals. Bisexual, an individual who is romantically, physically, emotionally, and or spiritually attracted to men and women. And I really do want to draw your attention to the fact that it is romantically, physically, emotionally, and or spiritually, and not just sexually. And we'll come back to that point again in a minute. Gay is an adjective used to describe people whose enduring romantic, physical, emotional, or spiritual attractions are to people of the same sex. Homosexual, a term originating from clinical context and is often considered derogatory by many individuals. And I say by many because there are some who actually embrace the term homosexual because the term gay has a socio-political context. And when we get to talking about what we can do, it's important to let the patient sometimes guide us through the lexicon so that we understand from the patient's perspective what are the terms that fit for them. Lesbian as a term refers to a woman who's enduring romantic, physical, emotional, and spiritual attractions to other women. And the term queer speaks to, which was, when I was growing up, it was a negative term if somebody called you a queer or a punk or a fag or something like that, these terms. But in fact, increasingly, youth have embraced this terminology. And it refers to some value or term, and it's embraced as a term of defiance. And some like it because it can be inclusive of an entire community. And then again, there are locally and colloquially used terms, so I really encourage us not to see this as the end of the lexicon, but an introduction to this lexicon. There are additional terms that have to be addressed in this discussion. And we talk about gender identity, sexual orientation, and sexual behavior and practices. And many authors have written about this from the personal attributes questionnaire in the 80s and late 70s forward. And people talk about the relationship between biological states of being, gender identification, sexual orientation, and sexual behaviors. But a gender identity is the way in which an individual identifies with a gender category, which is often socially identified at birth as one of 2 genders, the blue babies or the pink babies. The babies with the baseball bats and the babies with the baby dolls. We introduce these kinds of social connotations very early on, and people start to embrace those. Even though I've done this work a long time and I've lived in this body for more than 50 years, I've yet to meet somebody who was raised from the cradle to be gay. I've not met that person. So what this ultimately means for me is that individuals who are gay, lesbian, bisexual, transgender, queer questioning actually were born into and very often raised with this understanding. And so sometimes it creates an internal conflict, an internal process that has to be digested and synthesized against many social, political, and other elements that often defy what the person sees themselves to be. So we move to sexual orientation as a term, and it refers to one's sexual and romantic attractions. These are the things that emerge before there are often identity labels put to them. It's the things that make you feel good. Often I like to liken it to a preschool playground where you tell the kids, grab the hand of your best buddy. And more often than not, you're going to grab somebody of the same gender. But then you go to a high school basketball court and say that, and it doesn't happen. So what do we do to people between the ages of 3, 4, and 5, and 14, 15, and 16 to make them not feel safe and secure with who they said was their very fundamental best friend and their ally. And we create interesting barriers as social entities for individuals. And then there are sexual behaviors and practices. And I think it's important to distinguish behaviors from practices. Behaviors are more like tactical acts, things that we do, and they may be situationally defined. They may be defined by, in the work I do, very often by economic and social conditions, trading sex for drugs, for example, being incarcerated, situational sex, compared to practices which are the mosaic of how people put together a consistent set of behaviors over a period of time. And so again, people can engage in certain sexual acts tactically based on circumstances, but that may not necessarily define what they perceive as their practices. And I have to say this, one guy once told me in a qualitative interview, you're not homosexual if you don't do it consistently. So in other words, if you only do it on every third Tuesday of the 4th month, then it doesn't mean that you're homosexual. If we look at additional terms, it's important to recognize allies, and I hope that if you're not already an ally, by the end of this presentation or at some future point, you will see yourself as an ally to the LGBT community and the issues of assuring and achieving optimal health care. We have to address issues of heterosexuality and heterosexist views. And heterosexist view is a view that of prevailing dominance of heterosexual worldviews and services, practices, and programming. Again, the world in which we exist actually operates out of a very heteronormative worldview where heterosexual practices are viewed as normal and anything else is abnormal. And what this creates is a binary thinking, normal, abnormal. And that probably fits in very well with some of the things that we think about when you look at lab results or you look at diagnostics. It's either normal or it's not. But we actually start to convey to people in languages that we use when we have an instrument that says, are you male or female? And there's no other category on the instrument for anything in between. When we have a bathroom that says male or female, the students at the Hunter College School of Social Work made a very loud proclamation, and we had to create an all-gendered bathroom to assure that individuals who didn't fit in one of those two binary boxes felt there was a place that they could go. And so it's that kind of a thinking that I'm asking you to consider when we think about the practices that we as providers bring to the table, we as systems of care bring to the table, that very often our heteronormative worldviews permeate the kinds of interactions that we have with patients. In constructing our understanding of the LGBTQ health agenda, it's important to construct patient, family, and provider organizational responses that do not essentialize or reduce the individual to his or her sexual practices or sexual behaviors. So often it's easy to ask somebody, are you gay? And then from the gay, you quickly go to the sex. Well, you know, I know individuals who identify as lesbian, gay, bisexual who have not had sex in years for very many reasons. And they're not at risk sexually, but they're in emotional, psychological, or social realms where they do engage with the community. And if we make the fundamental flaw of assuming that gender identification is about sex, what we've done is essentialize based on our worldview of what these terms mean and not based on what the patient understands that means to him or her. And that brings us to two terms that, in fact, in my current project of a new CDC study, that we're looking at issues related to male sexual health and sexual well-being, and the team from across multiple sites, we're actually grappling with these concepts of sexual health and sexual well-being. And so these are definitions in emergence for me. But sexual health broadly relates to the ability to knowingly and optimally engage in desired sexual expressions and physical and intimate expressions. optimally, knowingly, not coercion, not interpartner violence, not force, but optimally and mutually probably should be added to this, which is contrasted to sexual well-being, which is broadly the capacity to integrate one's sexual, gendered, and intimate desires into a whole and healthy life experience that transcends work, leisure, health, and other spheres. So your sexual well-being, I like to see, is bigger than just your sexual health. When we assess a patient, it might be important for the patient to understand biological health risk, sexual risk, but their sexual well-being may actually go into their spiritual realm, it may go into their employment realm, it may go into their leisure realm, other spheres. And so I really do believe that it is important, and the literature would tend to support, that there's something more complex than just the sex of the person that we have to attend to. I do want to make a comment about the historical consideration here, that we're not talking about a long history. I already told you about the literature review that I did before coming over here, but it was only in 1973 that we eliminated sexual orientation as a mental disorder from our diagnostic regulations. So we're only talking 38 years, less than 40 years, and for many of us, that's in our own lifetime. We're only talking in the realm of 22 years, where the AMA adopted from its medical student section a resolution prohibiting discrimination in admissions to medical schools based on sexual orientation. And we're really only talking about 13 years since the AMA adds a non-discriminatory clause on sexual orientation. 13 years. So I don't think there's anybody in here under 13. I don't think. I could be wrong, but we're not talking about a long history here. So when we think about, well, of course this is something we should do, everybody does it. The reality is not even within our own professional realms do we have a long history of doing this. And when we look even more closely at things that emerged like Healthy People 2010, and I suspect many people in the room are familiar with Healthy People, but it's the Health Promotion and Disease Prevention Statement of National Priorities that comes out every 10 years, and we're at the point of embracing the goals and guidelines of 2020. There are specific goals for LGBT health, and these goals are specifically related to reducing disease transmission and progression, increasing mental and physical well-being. Again, that word well-being, not just health. Well-being broadly written that cuts across work, leisure, and other spheres, and reducing healthcare cost and increasing longevity. So it's important to recognize that yes, there are regulatory demands, yes, there is a body of literature, but this is all cast in a history of less than 40 years that we're asking our patients and our providers to come into, and together we're if not dismantling, we're at least responding to the history, as Paul Starr would probably write in The Transformation of the U.S. Healthcare System, these structures that so predated any of us being here today. So when we think about and we look at the synthesis of the literature, and we think about some of the specific issues that impact LGBTQ persons, negative encounters with medical institutions themselves, the institutions coming in and being fearful and finding that there is only a male or a female bathroom, coming in as an LGBT person or a transgendered person who hasn't legally changed their name yet on their official records, and being referred to by a different gender than a gender that they don't identify with in their current space. Lack of attention to the diversity in sexual expressions and the differences between sexual health and well-being overall. Disproportionate rates of substance abuse, depression and anxiety, overweight and obesity, tobacco use. These are all leading indicators in Healthy People 2010 and 2020 that are being proposed as critical elements that we need to address in an LGBTQ health agenda. Interactions between sexual, class, and racial discriminations, because individuals don't exist in one sphere. So it may look very different for a lesbian of immigrant status who is economically empowered than it looks for a transgendered individual who is US born and doesn't have the same economic resources or educational experience. The role of social networks to support the patient. Who supports the patient when we give directives or we make decisions around health care? Who do they go to? Is it a family of biological origin? Is it what we call a fictive family, which is a family created by the individual? Do we create space in our healthcare industry to allow the patient to bring those individuals and systems to the table for important discussions? And if we're not, then we're contributing to potentially the negative health outcomes for individuals. The literature would also say that we have an overemphasis on individual behavioral models to healthcare that often don't include contextual, systemic, and social cultural practices, such as issues including discrimination and access to care. Access to care is an important and fundamental barrier to treatment. Where do I go? Is it coming at an hour when I need it? When we think about LGBT health and LGBT care, there are many lesbian, gay, bisexual, transgendered individuals who are economically disadvantaged. Not that there aren't other groups, but I know personally some transgendered and working men and women, when I say working, I'm talking sex industry, who work different hours. And so they don't necessarily operate by an appointment book. They don't necessarily operate by coming in between 9 and 5. That's their sleep time. Their lives are organized very differently. And so are we creating appointment schedules and systems that actually attend to some of these very fundamental differences that may exist among and between individuals? Have we addressed the underlying issues of stigma, which also include overtly or covertly outing a person? If we bring a person in and have a discussion with an individual and we indicate on a medical record somewhere that the individual is gay, bisexual, transgendered, that person may be very concerned about what the health insurance form will do with that information. And so that person may be very reticent to reveal to you information that may appear in a medical chart somewhere that would allow you to better provide service, but because of perceptions of stigma, because of perceptions that you may judge them, they may not be able to engage in a very open dialogue with you. There's limited attention to developmental needs of individuals. Yes, there are articles about older individuals, there are articles about youth, but we don't really talk about LGBT issues as a continuum. And if, as in Healthy People 2020, longevity is an issue, we really have to construct a mindset. How do we move an individual who is LGBT at adolescence to a senior LGBT person who is living in the most optimal environment and state that he or she can? And so and again, remember, this is only held against 13, and if you stretch it, 40 years of really purposive practice in this area. And so we don't have a lot of knowledge about what constitutes very good lifespan care. Issues of religion impacting patient and provider realities. The patient themselves come with certain concerns, and we as providers may hold some of those values as part of the way we perceive what is appropriate and what is not appropriate. Issues of class impact access and utilization. Discomfort with the topic and gender. I believe when you look at the literature that I gave you, the abstracts that I gave you, that it's not just the patient that is discomforted by this topic. We don't necessarily live, as US citizens, we don't necessarily live in a sex-affirming society. We actually live in what many people have termed a sex-negative society. We tell people not to do it, but please do it. And we create this dichotomous thinking where we create a very interesting industry around not really talking about sex, but promoting it from everything from toothpaste to dog food. Sex is fundamentally part of the way we view the world, but we don't really have healthy discussions about it, let alone healthy discussions about non-heterosexual forms of sexual expression. perceived knowledge of the importance in the assessment. Oh, why bother with that issue? It's really not important to a broken arm. It's not important to osteoarthritis. It's not important to recovering. Well, in fact, it probably is, because if we're not treating the whole patient, if we're coming with perceptions about who this patient is or should be, then we're probably not, back to the issue of inequalities and disparities, we're probably not using the optimal state of the science to produce the desired outcome for the populations that we are intending to serve. So it's really important to consider this factor. And fear of discrimination, as I previously indicated, and past prior experiences of discrimination. So it's not just a stigma or perception of stigma, but has the person been discriminated against before? Because now coming into you, you're a well-meaning and informed provider, but you are one of 17 providers this person has seen in their lifetime, and the other 16 have really done harm to that person. They've really done or said things that made the person feel that the healthcare industry itself and the patient-provider relationship is not a safe place to be. So it may not just be about you, and you know from your own practice that sometimes we have to go that extra mile to create the sphere and space for the patient to be safe. Fear of those economic implications, again, related to health insurance and employment, biases of the systems, implicit biases towards binary or heteronormative worldviews, and limited organizational and or regulatory demands. Well, oftentimes, if all else fails, the regulatory demands push us into a space where we have to consider these. So again, if we think about the Joint Commission and others, we're actually being thrust, not just your hospital, but all healthcare industries, we're being thrust into a space where LGBTQ issues are being claimed and put out there as such to be important topics for us to consider. And again, I think that your hospital, your standard of care is well situated to be able to incorporate, if not lead advancements in this area. So as Bird and Clayton would write, whether sensational or mundane, the inappropriate responses to the LGBT communities are deeply embedded in the structures of and the culture of American healthcare system. And they would continue, and we have to be cautious about one-size-fits-all resolutions. And I say this as a caveat before we go into talking about some of the actions that you can take as individuals and systems. I will be suggesting activities, but those activities have to be held against the capacity of each of you as individual providers and of the system of care. Because if we had a one-size-fits-all, then it would kind of be like waving the magic wand and you do it and it's all taken care of. Well, that's really not going to be the case, any more than it would be the case for you to get a diagnostic on a patient and not to understand that medications and rehab therapies and surgeries have different outcomes for different patients given the individual realities of the patient and post-patient care. And again, so we can't reify the science to believe that just by attending Darrell Wheeler's lecture that you're going to be able to do this without doing some internal assessment at the individual level and at the organizational level. Specific healthcare needs of the community, and I cite a few, and this is a synthesis of many of the articles that you'll have in your packet and that I cite here. But overweight and obesity as associated with cardiovascular complications. And this is a very interesting array of situations. Some authors suggest that we see obesity and overweight conditions because individuals don't feel compelled to exercise because their views of themselves as lesbian or gay or transgendered individuals doesn't fit the images that they think are out there for heterosexual individuals. So they draw in. But it may also be associated with anxiety and depression, and we do know that there's a relationship between stress and anxiety